and specifically the causes, the pathophysiology, diagnosis, and treatment of this very common disease. I want to kind of show you what's going on at the bronchial level. You remember, if you look at our pulmonary function test discussion, we looked at a flow volume loop. And what happens when you blow out air very quickly, your forced expiratory volume or flow rate goes up very quickly and then comes down, and then you take a inhalation in. And this obstruction that occurs in asthma and in COPD occurs in this area here, which is the small airways. And as that obstruction gets worse, you see a decrement in the flow rates, especially later on in blowing out. And the point here I want to make is that these are the small airways. So this is where asthma is occurring. It's obstruction of these small airways, not the large ones, but the small ones. And as such, I want to diagram what it is that's going on. So you've got the airway, and this is a very simplified version of what it is that's going on. You've got this lumen of the airway that's here, and as you may know, it is lined with smooth muscle. When that smooth muscle contracts, this lumen gets smaller. Okay, so there's two major things that are occurring in asthma or obstruction of these small airways. Is you've got some sort of an inflammatory process for whatever reason that's going on here. This inflammation stimulates certain cascades that occur, and it causes smooth muscle constriction. And as a result, the inflammation causes the lumen to get smaller and smaller and smaller, until finally there's wheezing, there's obstruction, and the primary problem is that you can't get air out of these small airways. And that is why in an asthma attack, you will see that this flow volume loop comes down and the flow rates in these small airways is almost non-existent. That's when you run into asthma attacks. Now, the severity of this contraction is going to give you the severity of the asthma attack. And how we affect this and what the pathophysiology is of this is going to determine how this is treated. So let's talk about that a little bit. Once again, I want to emphasize that in asthma, what we have is reversible airway inflammation. That is opposed to irreversible, which we would see in COPD, where this airway inflammation has occurred and this constriction has occurred. In COPD, it's kind of irreversible. In asthma, we can actually reverse it back to almost completely normal. This inflammation and constriction can sometimes be mediated by IgE. So sometimes you will see elevated IgE levels, and that fits into the pathophysiology and the treatment. What is IgE? It's an immunoglobulin. Specifically, it's an immunoglobulin E, and that's important because immunoglobulin E affects a cascade that releases histamine, which causes swelling, which is going to make the area in that bronchiole even smaller. IgE uses the basophils and mast cells. These release histamine. There are ways of preventing these cells from releasing histamine, and that is sodium chromoglycate. You'll see, for instance, medications like cromolyn. Sodium chromoglycate is used to stabilize these mast cells and basophils and prevent histamine. So sometimes we actually use that in the treatment of asthma. Okay, so again, I want to review. The bottom line here is that we've got a situation where you have inflammation, which causes constriction of the smooth muscles in the bronchioles. So let's talk a little bit about this smooth muscle then. Okay, we've got nerves that affect this smooth muscle. Two types of nerves specifically, and they have receptors. The first one I want to talk about is the beta receptor. So you have a nerve that comes down and it releases compound, which hits this beta receptor, and this causes relaxation. Then there's another receptor, which is the muscarinic receptor, and that causes constriction. And so in both asthma and COPD, as it turns out, we want this muscle to be relaxed. That's the goal. We want relaxation. And so what we're going to actually end up doing is activating this receptor, and blocking this receptor. And so what you see is, pharmacologically, we're going to be using anti-muscarinics, and we're going to be using beta agonists. That's how we get to the treatment. Now, the other thing that we're going to see pharmacologically, and we'll talk about this, is inflammation. Inflammation is going to cause constriction because of inflammation. So what we're also going to use is anti-inflammatories. So what I've just shown you here are the 3 cornerstones of asthma treatment. Some of them are going to be used first because they're much more effective than others. And you could probably guess which one is going to be most effective. Because inflammation is starting everything off, the anti-inflammatories are going to be number 1, the beta agonists are going to be number 2, and the antimuscarinics are going to be number 3. Okay, so we'll get into the pharmacology of that. Let's talk about the pathophysiology, about perhaps clinically where this inflammation may be coming from. Things that can trigger problems in our airways based on a number of things. First of all, because of the stuff that we breathe in. So that's a trigger, the air that we breathe. What else could trigger asthma? What else could be causing it? Well, there's a tube that sits right next to the trachea, which goes down to the stomach, called the esophagus. And sometimes stuff in the stomach can reflux up and irritate the airway that continues up. So another thing that can cause this is gastroesophageal reflux disease. That can sometimes cause symptoms of asthma. Now if we go up here, we have the nasal passageway. Sometimes you can have allergies that drip down and cause irritation in there. So then post-nasal drip can cause asthmatic symptoms. And so whenever you see a patient with asthma or you're asked about it on a test, you should think about these things as causing asthma. So what we call cough variant asthma, post-nasal drip, and gastroesophageal reflux disease. Some of the other things that can contribute to all of these, think about down feather pillows, pets in the bedroom. These are places that you spend a good 6, 7, 8 hours a day and could affect some of the treatment symptoms. So these are some of the things that by getting rid of, we might improve asthma. There's also environmental things and things from work. For instance, from your occupation, there's something called isocyanates, or cotton dust, wood dust, solvents. All of these things can, by breathing them in, set off asthma exacerbations. There's one other thing that I should make you aware of that they might ask you on a test. They love to ask things that are uncommon in asthma that could be very unique or make you think of something. And there's something called Samter's triad, where you see number 1, aspirin sensitivity, number 2, asthma, and number 3, nasal polyps. Now, when these people take aspirin or any type of NSAID, what can happen is that these medications inhibit cyclooxygenase. And as a result, they're going to have increasing compounds that are going to set off asthma exacerbations. The key here is that within hours of taking aspirin, they're going to start to feel flushed and they're going to go into an asthma exacerbation. These patients who are typically sensitive to aspirin or NSAID products are also going to have nasal polyps. The key here is that they need to stop using aspirin and NSAID products and find an alternative. These patients, by the way, and we'll talk about treatment, also respond very well to leukotriene receptor antagonists, and we'll talk about those. So just remember Samter's triad in your patients with asthma. Ask them if they've had a history of aspirin sensitivity or if you've noticed that their symptoms have gotten worse after taking aspirin or NSAIDs, and then ask them about a history of sinus problems, maybe even sinus surgery or nasal polyps. Okay, well, join us for part 2 where we talk about the diagnosis and the treatment of asthma.